Well, hello everyone. Hello, whoever is tuning in. I am Chirag Thakkar and you're watching Roli Pulse, a digital initiative by Roli Books. We are going live right now in association with Scroll.in, Crossword Books, and Shopperstop. And you're watching this live right now on Roli Books' Facebook and Twitter pages, as well as the Facebook pages of Scroll.in, Crossword Books, and Shopperstop. So wherever you are tuning in from, thank you. In case you miss seeing this live, right now we'll be posting it on our YouTube channel. And if you lose the connection midway, you can also find the same video on YouTube. For over 4 weeks now, since the lockdown began in India, in the absence of books in bookstores, we and Roli Books have been bringing you these engaging live sessions, recorded chats with writers, artists, public intellectuals, sports persons, industry leaders, historians, journalists, among others, via our digital platform Roli Pulse. And I want to thank each of you who have been tuning in, sharing your comments, asking questions, sharing this video with others. Just like the previous sessions, you can share your responses. Ask our panelists questions if you're watching this on Facebook or Twitter. And if you are watching this particularly on Facebook and Twitter, you can share this on your timelines and start a watch party. We will also be posting this later on our YouTube channel as well as our Instagram TV, which is the IGTV. Today's conversation is perhaps one of the most pressing, relevant, and a much needed one. A few weeks and months, depending on where you are and which part of the world you are watching this from, into this lockdown. The world as we know it is no longer the same. While we are all in this global simultaneous trauma, a pandemic, and this kind of lockdown together, we're also experiencing this at our own pace as individuals, communities, neighborhoods, states, and nations. And this evening, we bring to you a varied set of voices to talk about this specific global health emergency and what lessons we can draw from our present and the past for the future that we are all going to be part of. Joining us in this very pressing and relevant conversation are Kiran Mazumdar-Shaw, Lakshmi Subramanian, Ramanan, Laxminarayan in conversation with Maya Mirchandani. Kiran, as many of you know, is executive chairperson at Biocon Limited, a successful technocrat of global standing. She heads India's leading biotechnology enterprise, Biocon. Kiran is highly respected in the corporate world and has been voted by Nature Biotechnology as the most influential person in biobusiness outside of Europe and the USA. We have with us Ramanan Laxminarayan, who's the founder and director of Center for Disease Dynamics, Economics and Policy in Washington, D.C. He is also a senior research scholar at Princeton University and affiliate professor at the University of Washington. Since 1995, Ramanan has worked to improve the understanding of antibiotic resistance as a problem of managing a shared global resource. We have with us Lakshmi Subramanian, who is an Indian historian with a long and distinguished teaching and research career. Post her tenure as professor of history at the Center for Studies in Social Sciences, Calcutta, she's been researching with the Godrej Archives in Bombay. Currently, she's professor at the Humanities and Social Sciences Department in BITS Pilani, Goa, and is also associate member at the Institute of Advanced Studies in France. And we have Lakshmi, Ramanan, and Kiran in conversation with Maya Mirchandani, who is an award-winning Indian journalist with interest in Indian foreign policy, South Asia, and identity conflicts. She moved to research and teaching after over 2 decades at NDTV India. Maya teaches media studies at Ashoka University and is also senior fellow at the Observer Research Foundation. So welcome to Roli Pulse, Kiran, Lakshmi, Ramanan, and Maya. I do hope you enjoy this chat, and I'll just hand over to Maya to get us started.
Well, thanks a lot, Chirag, for that wonderful introduction. And it's great to be on a panel which is so illustrious and has so much to contribute to this conversation and trying to understand the times we're in. But I'd like to start with Ramanan Laxminarayanan, of course, because a lot of what you put out in terms of numbers and data in the early weeks, preceding the lockdown, when India was first beginning to sort of recognize the concerns around the coronavirus. You talked about how over 250 million Indians would be infected, how there would be a lot of deaths in India. Are you pleasantly surprised with the fact that those numbers haven't met your predictions?
Thanks, Maya. And this is something that I always like to have an opportunity to explain. So where do we start? Mid-January, we had the Wuhan epidemic really getting out of control. India had already stopped flights to China. They brought some people back by the end of January in those special flights. There were 3 patients who were infected. They fortunately arrived in Kerala, which has a good health system. They were quarantined. No further problem from there. But into most of February, we didn't do a whole lot because we weren't really sure about how badly it was going to affect India. But by the mid-February, we already began to see what was going to happen in Italy and Spain after that. But there still wasn't a huge amount of action beyond that initial screening, which was mostly focused on passengers coming in from the east side. And what we knew by then was that most patients with COVID are asymptomatic. So just screening passengers for fever at the border was not going to be a very effective measure to prevent people from coming in. And certainly by early March, we had a bunch of cases, mostly from people who brought it in from Italy, Italian tourists, but also Indians are coming back from Europe. And those were the first cases that truly seeded the epidemic. Now, what was concerning to me starting from early March, when this was clearly getting out of control, was a narrative that was building up, which was that somehow Indians are immune to the virus. We're not really going to get it because we're very different. We have better exposure to viruses, or we say namaste, whatever else it is. And that was a very worrying narrative, because this particular example, which is of a new virus which attacks a completely naive population, is one that you see only in textbooks. We teach these to students at Princeton, and this would be the kind of project that my undergraduates would do as a modeling exercise. You never get to see this in the real world. Actually, when you see this happening, and with a reproductive number like 2.7, which means every patient infected creates 2.7 additional infecteds, you get to large numbers extremely fast. Now, India had the advantage of, first, that our first cases probably came in much later than they did into Europe or into the US. Now we find out that the US probably had early cases back in January itself, because they have a lot of back and forth traffic with China. So the predictions that we made in early March, which were through to July, and remember, we're not in July yet, were over 300 million cases. And remember, over 300 million infections of which the vast majority would be mild or asymptomatic. That's what most people forget. We always said they're going to be mild or asymptomatic, but because of India's population, even if a very small proportion of those ended up being severe, the fact that we only have 100,000 ICU beds in the country means that even if you had 600,000 or 1 million or 1.5 million severe infections, things could turn really bad because we don't have the capacity. And certainly by that time, it was hard to get people to socially distance. You saw these religious gatherings that were going on with hundreds of thousands of people. No one was really paying attention to the request to not have these sorts of gatherings. And that was the scenario in which a lockdown was advised and came into place March 24th. A lockdown is an extreme measure, but it seemed that none of the intermediate measures were really working in India. So if we are not seeing cases now, it's a function of two things. We got cases much later. So we ran about 4 or 5 weeks behind Europe with the epidemic. And the second is, of course, the lockdown, which has a tremendous impact on flattening the curve. Now, let's be clear, there's a lot we still don't know about the virus. So we're learning these things every day. Literally, it's like an education every day based on the research that's coming in. So by no means can we be definitive. I don't doubt that the disease will spread widely. What we don't know is the numbers that will be severe cases and the numbers that will be asymptomatic as a proportion of that total number of infections.
So if I can just ask a quick follow-up to that before I move on to the other panelists. I mean, I take your point that, your predictions are till July and you're talking about a number of people infected. You're not talking about the severity of that infection. And you were basically, your concerns were about what proportion of the population would be asymptomatic or mild versus.
And also, sorry to interrupt. And also, this was if you did nothing at all. So this was
right.
With no lockdown whatsoever.
Correct. I understand that. But so I would like to ask you that in given the proportion of cases that we have seen, the ones that have been tested, I mean, we can go into the arguments, and Kiran will talk towards that in a bit about the lack of testing or how much testing has been done. But out of the proportion tested, the severity, the fatality is not at the rates we've seen in Western countries. We've seen a clear sort of, I don't know if it's, I don't want to speculate. I'm not a health person, a public health person. I'm not a medical person. But is it that we've seen a milder strain of the virus? Is it that people in the subcontinent, I mean, we're looking at numbers across Pakistan, Bangladesh, India, is there some kind of herd immunity that the public already has? I mean, what do you think are the reasons why we've just not seen the kind of the deaths, the infection rates, the fatality, mortality rates that we've seen in Italy or in the United States? I mean, just take what's happening in the US, for example, where the healthcare systems are better equipped to deal with a pandemic, with an epidemic than we are.
Right. So I'll give you a very brief response here, because I think the others should weigh in. I think fundamentally the answer is just the two that I gave you, which is what the lockdown does is pushes out a curve. It doesn't necessarily flatten a curve. It just gives us time. And that was the idea behind the lockdown, to get us through to July so that we get all those beds ready. The reason I think, and this is again based on only what we know so far, that we have not seen the rates of infection that you see in the West is simply because we are running about 4 or 5 weeks behind those countries in terms of the outbreak. And if you take Mexico, for instance, which has 1/10 of our population, similar temperature to India, is already also in the same season, for instance, Mexico, 1/10 of the population has over 1,000 deaths and more infections. So there is also no evidence that we have a milder strain. If there is, we don't have evidence of it. Let me just put it that way. So we might just be lucky in terms of running a few weeks behind the epidemic. And remember, 4 or 5 weeks for an epidemic like this is a lot. I mean, every 2 weeks you're going to have exponential increases. So we're lucky with respect to the delayed entry. Number one, Pakistan got it from Iran. Pakistan didn't get it directly from China. We got it from Europe. The second is, of course, that all these countries, whether Bangladesh, Pakistan also, they resisted a lockdown initially, but eventually, very quickly, they also put a lockdown in place. And India, we were lucky to get a lockdown very early, whereas in the US, there was no real lockdown that happened, and in Europe, they started imposing the shelter at home only after the epidemic peak was really climbing quite a bit, which is quite a late time to do it. So I think we've both been lucky, and we've done some things early. But that doesn't mean that we've seen the end of this.
Okay, let me bring the others into this as well. And Lakshmi, I'd like to actually come to you next, because a lot of what we're talking about today has to do with how India has dealt with health crises in the past as well. What the state of our preparedness has been, what our public and community responses have been, and also in terms of, globally, how have epidemics or pandemics, as COVID is, really changed the way, the world sort of understands its context and what's going on. So just weigh in on that, because, as a historian, how would you compare this to, I mean, what would you compare it to? What's a case that you could compare it to?
Yeah. Thanks, Maya, for that question, and hello to all. I'm going to try and answer this question in two ways. I think as a historian or a student of history, definitely, I think the challenges of writing in the present are always difficult, because when you write history, you always have the advantage of retrospective insight. And therefore, you can sort of reflect on what happened and then think and offer sociological explanations to how the epidemic came, how it was received, how governments responded, whether we had adequate healthcare systems, and so on. So this pandemic, as a historian, is sort of bewildering, because in many ways, it just tells you about the challenges of writing something which you are witnessing in the present. On the other hand, I'm not very keen on drawing immediate parallels from what happened in the past, because I do think that while we have lessons from history, I don't think it gives you the exact formula to deal with, the situation
Right.
that we're in now.
Right.
So I would be hesitant to compare, say, COVID-19 with the influenza that, was sort of wrongly termed the Spanish flu. It wasn't the Spanish flu, but shall we say the influenza of 1918, and which in fact took away many more people in India than COVID has now in the
Yeah.
rest of the world. So I think an easy comparison of epidemics is sort of a little difficult and can be very disheartening. But to answer your question more practically, I think, history definitely tells me one lesson, which is there is almost a timeless fear that we associate with epidemics. And I'm not always sure that that fear is from the real experience of human suffering, which undoubtedly you had with the plague in Bombay or the pandemic in 1918, has to do with certain kinds of communication. So I think a lot of what I feel now is drawn, this fear, the stigma that, we're always sort of encountering in relation to the COVID-19. So there is this sort of mad, hysterical dumbing down of what, say, Ramanan says. So you have a lot of people saying, oh no, he has no idea, these numbers can never happen to us. I think this kind of fear and this kind of looking away from scientific, rational model making or epidemiological insights, I think is very dangerous. So I think here we don't seem to have learned our lessons from history. We seem to be faltering in pretty much the same way. We are still, we still think it's important to say that we have done not so badly, the West has done badly, rather than thinking about what does good communication entail? What does the state have to do? What is state responsibility? How can we be more socially empathetic to thinking about labor and livelihood and indeed the fear of pandemic? So I think I would prefer to stay with the present, try to come to terms with what one encounters in the present, and then draw some hope from the lessons we may have learned or may have chosen to forget. So that would be my immediate response. Can I compare this to the 1919 influenza? Yes and no. I think man has cohabited with the flu for a long time. We may forget those modes of cohabitation. We, of course, have a full-blown crisis in our hands. And I think we have to learn from certain lessons and be very alert to the way in which government, civil society, and us as the general public, treat this disease, and more importantly, treat the disease in our social body, not just treat the disease in our individual body. So I am much more concerned with the social ramifications of this problem rather than simply say whether we are prepared or not prepared. Maybe we are, maybe we are not. I think we have to wait and see.
Right. Okay. You raised that very important point about fear, and that's where I want to bring you in, Kiran Mazumdar-Shaw, because fear and stigma around the disease, fear of whether I'll get it, whether I'll get it and I'll be asymptomatic, so I won't know. Will I pass it on to somebody else? Oh my God, what will my housing society say if I fall sick? I mean, we're seeing all kinds of manifestations of this fear, but at the end of the day, people are also looking towards science to deliver us from that fear. And you deliver us in terms of, treatment protocols, in terms of better testing. We've had reports about how all these test kits have actually not worked. They've been faulty in the last few weeks that have been going on. And of course, this race to a vaccine, it's a global race to a vaccine right now. So just to ask you, for firms like yours, for entrepreneurs like you, for technocrats, for people in the healthcare space, I mean, this is probably the biggest challenge you're facing of your career.
Yeah, I mean, I think we are all living through very surreal times. I mean, nobody expected this pandemic, this microscopic monster to come and just disrupt our lives. But, let me just a couple of things. You mentioned about the fear psychosis. You mentioned something about the stigma. I agree with both my panelists that, look, I think you need very clear messaging to basically take this paranoia out of people. For instance, when I look at some of the data today, I feel that we are in a more comfortable position than we were maybe in March. Ramanan talked about some of the data points which really got him to make these kind of predictions and modeling. But, let's not forget that we did impose that lockdown. And by doing that, and by the way, I must also tell Ramanan that contrary to your comment that, we were just taking temperatures of, the passengers coming into India, we did much more than that. We actually quarantined all foreign travelers. I can tell you that anyone coming off a foreign flight was quarantined at home. And you will not believe it, Ramanan, they were checking on you. I mean, it was amazing for me in Bangalore. This is what happened. I mean, there were people, health officers from the Department of Health calling up to make sure you were at home and that you were quarantined. This was amazing. I've never seen this happening. Okay. And, so there were a lot of very stringent measures taken even at the time of quarantine. Of course, later on, the lockdown came. Now, if you look at the day, see, first and foremost, 5.5 weeks is a long lockdown in which to actually slow down the spread, to deal with preparedness. And that's what we've all been working at. I'm in several task forces and I'm trying to see what should we have as a state of preparedness. And when I start looking at certain data, you asked about testing and positive cases. There is something called TPR, or the test positive rates. Okay. In India, 1 in 23 people are testing positive. Of course, you can debate on whether we are testing enough or not.
Yeah.
But that's the rate right now. Now, that is about 4.4%. If you compare that to New York or US, it is almost 20%, which means 20 out of 100 people tested are testing positive. You look at, Europe, it's around 18%. You look at even Japan, it's almost 9%. So we are actually doing quite well in terms of TPRs. Now you look at the slowing down of the spread. It used to double every 3 days. Now we're doubling every 10 days. So, okay, you may start looking at these numbers and saying, okay, so what does all this mean? I am simply saying that, look, we've done certain things very well. We have actually, in many parts of the country, definitely Kerala and Karnataka and many states, we have started zoning and containment.
Yeah.
So every time you see a spike in the number of cases, we are cordoning off and sealing off that particular zone, okay, or that particular suburb or whatever it is. Even a small housing colony is being zoned off. And you're sealing it off. Now, you saw that in Bombay, for instance, they had a big outbreak in two areas. One was Dharavi and one was Varli, Koliwada. And Koliwada was actually sealed off and they haven't seen any more rise in cases. So that was very well done. But Dharavi is seeing a big spike because it's a much larger slum. Now, what I'm saying is I'm not so concerned about the number of positive cases, because positive cases, like Ramanan says, will be much more. I think infection will be much larger than what is being reported today. And we haven't even tested half the asymptomatic carriers of this COVID-19. So I'm not going to be surprised if you see a huge surge of positive cases. My major concern has been, what is the mortality rate? What is the level of seriousness or severity of the disease? That is more important for me than just the positive cases, because if we have a treatment, when we get a vaccine, we'll feel far more confident, okay? And if our positive cases are mild and asymptomatic and they're recovering very fast, which most of them are, and my theory is that 90% of our population is below the age of 60. If you look at globally, 80% of the deaths have happened over the age of 60. So when you look at this kind of numbers, you feel that yes, we are going to get infected, but we have a much younger demographic, and that's why we're able to deal with this particular in a much more robust way than Western populations have, which are aging populations. And if you notice, in where most of the the deaths have taken place in, say, northern Italy, a large 50% of those deaths have taken place in old people's homes, because that's where those old people are living together. So you have to look at all this data, and therefore I feel that we are in a better place. And what I'm also hoping is that from the 3rd of May, we should do a calibrated opening up, because now, we've saved lives, but we need to now save livelihoods. And I think when you look at livelihoods, I really believe that you need to do it in a calibrated way. Of course, you can't open up, big public spaces. You're not going to have sporting events. You have to start getting workplaces at least opened up. And in the workplaces, I really believe that opening up has to also go hand in hand with testing. Now, you asked me about testing. When we started off on this journey in early March, I can tell you we didn't have enough test kits. And when we got a task force together, we realized that we were not going to get test kits from abroad, because all these test kits were going to go to the US and Europe, because that's where the huge impact was. So we very quickly realized we had to produce indigenously made kits. And very quickly we came up with quite a few companies in India who made these kits from assembled imported components, and they're doing pretty well. Now, we started off doing less than 10,000 tests a day. A country like India, we need to do at least 100,000 tests a day.
So if I can just interrupt you on the testing, Kiran, I mean, one of the concerns around the test kits, apart from, whether they are the cold chain is being maintained and things like that, we've seen some of those reports as well, but is also the cost of testing. I mean, it seems prohibitively expensive for when private labs started to do these tests. I mean, the costs that
Maya, can I just interject right here? Because there's a lot of misinformation being given about the cost of tests. It's unfortunate that media has hijacked this whole debate to the cost issue. Please remember that right now, the private sector is hardly testing 10% of all the tests being done in India.
Right.
So 90% of the tests are being given free of cost. Government hospitals, government labs. Now, private sector was roped in to actually raise the quantum of
testing, right?
Okay. And the private sector was given a price by the government, because this is what they were procuring the kits at, and this is the cost at which they were doing the tests. So this is how much it's costing the government. Okay,
right.
This is what the government said. This will be your MRP, and the testing diagnostic companies have clearly said that if the cost of the test kits go down, we can also reduce our prices. Okay, because the large part of the testing cost is the kit cost. Kit costs reduce, they can reduce the costs. In fact, right now there's a lot of effort being put into reducing the cost of the kits. Now, so let's not get into that debate, okay? Because testing that is being done is very small. In fact, many people are saying, look, we are willing to give a certain number of tests free. In fact, now governments themselves are procuring large quantums of tests in the private sector at a lower cost, because obviously economies of scale count. If you have to do one test at a time, each test becomes so expensive, because you need one person to go in a PPE, which itself costs 1,200 rupees to go and test each person. But if you actually allow drive-in booths, if you allow testing booths where you can actually collect a lot of samples, where one person can collect
multiple. So that's South Korea model, where you can do a drive-in test, or like in France.
There are many models. We've also got it going here. But I'm saying if you do those mass collections of samples, you can bring down the cost. Let's get into that's not the main point. The main point is you've got those as PCR tests. Those are one type of test. You've got serological tests, which are where, Lakshmi or I mentioned, or you mentioned that some tests were rejected because they were not of good quality, because those are serological tests and they were not sensitive enough for COVID-19 tests. And so since the specificity was in doubt, they felt that you may not be testing COVID-19 patients. You might be just testing anyone with flu-like symptoms and saying they're positive or they've recovered, and that was not reliable. Now we have to actually get serological tests which are very specific to COVID-19, which means the antibody tests that we're talking about must be very specific to COVID-19 and not just to any other influenza or any other kind of coronavirus, let's put it that way, or H1N1 or anything. Now what we are saying is, because your body just produces antibodies when you have any kind of flu.
Infection, flu.
Infection.
Right.
So you don't want to make that mistake. Anyway, that test is important when you start opening up, because if you have a good test, you can actually start tracking people who have recovered from that infection. And that creates your herd mentality, which is okay.
Yeah.
So that's to give you an idea about the testing. We can do testing, we can have fever clinics, we can have drive-in testing and all the rest of it. And that is.
But Kiran, I mean, if I can just interrupt you, testing is one part of it, as you also mentioned. But what about in terms of treatment? I mean, how close are you to, is there an antibody treatment?
So
is there that convalescent plasma? Or the vaccine? I mean, there's a race to this vaccine. There's patents going out. There's, all kinds of things right now going on.
So let me take it in 3 buckets. So let's look at what's happening in terms of treatment. Right now, you're right. Before the vaccine comes, we need to treat patients and save them, right? So we are looking at any treatment that can rescue people and save lives, so to speak. So we've tried many kind of medications. You know that we tried the hydrochloro.
HCQ, that's right. Yeah,
HCQ we tried. Then we tried, and now we are trialing remdesivir. We are trying another antiretroviral from Japan. We are trying many things to see if any of them will work, right? As drugs. Now the jury is out there to see whether it is going to work or not. For instance, we know that remdesivir has not worked well in China. The trial data came out yesterday, which was very disappointing. But we've got some other data showing that it does work. And now we are waiting for the main data of a US trial, which is expected end of May. May or may not be the magic bullet that everyone wants. It's likely to be the magic bullet. Similarly, HCQ also turned out not to be the magic bullet because it has a checkered kind of data points. Now comes the other therapies. So the other therapies are plasma therapy, which is working, by the way. And this is an old therapy. This is not something new. It is well known. Even during the Spanish flu days, they tried plasma therapy and it worked, okay? But the problem with plasma therapy is you can't do it at scale. So, unless, of course, you can actually do it at scale if you get suddenly a huge number of infected people and who recovered and who didn't know that they recovered, but you suddenly found that these are all convalescent patients. And if really you have these 300 million or 30 million or whatever it is, you can probably take their plasma and recover any patients. But
that's right.
Being too facetious. Today, of course, you've seen the report that in Delhi, they did some plasma treatment on 4 patients and they're looking good. Plasma treatment does work, okay? Because you're basically taking convalescent patients' blood, which has neutralizing antibodies against COVID-19. You give it to those patients, obviously it will work. The vaccine. Now, when you look at vaccines, I mean, people are also developing antibodies which you can, mimic of the convalescent in a bioreactor, and that is also being developed, and that hopefully will also come into the market sooner than later. But I think everybody's eyes now is
on the vaccine. Yeah. So let me just actually on that, I'll just come back to you, Kiran, in a moment. Let me just bring Ramanan in as well on this, because, one of the questions, we're getting some questions from our audiences who are tuning in. One of them is, there's someone named Naina Ganguly who's asked that, essentially when we talk about this herd immunity, we're also assuming that there were a lot of asymptomatic, as you mentioned, carriers of COVID-19. how does one know that they're asymptomatic? Because again, we come back to the question of testing or the antibody testing, and it's almost like it's a chicken and egg thing. So how, in your assessment, would we be able to even, I mean, where do we see this going? We'll, at this rate, without the testing, without the antibody testing, without being able to be confident about the fact that just because you feel well doesn't mean you're not a carrier, where do we go from here?
Right. So I'd like to pick up on the separation that Kiran made. One is Rt-Pcr testing. The purpose of that, and Rt-Pcr is sensitive between about 2 and 10 days of infection, is primarily to identify people who need treatment and to identify people who need early treatment. So Rt-Pcr is looking for RNA in your nasopharyngeal swab. So basically, they swab and they get it. Now, the antibodies kick in, the early antibodies that kick in about 7-8 days, and then the long-term ones that kick in about 15 days. So testing will only ever give us the tip of the iceberg, always, the Rt-Pcr testing, which is why even though today we have 20,000 cases, quote unquote, we probably have about 15x of that in terms of actual infections. And the only way in which you find that out is not through Rt-Pcr. And this is not a failing of India. This is true anywhere in the world, is by doing the serological test. And the serological tests basically tell us, are we carrying the antibodies to the COVID or not? In other words, have we been exposed, whether known to us or unknown to us, we've been exposed in the past. Now, unfortunately, we have not yet carried out a serological survey across India, which would give us that information. When these surveys have been carried out in France, for instance, and there was a paper that just came out from the Pasteur Institute 2 days ago, they found that probably 6% of the French have already been exposed. Now, that's good news because they didn't have a huge number of cases and deaths, but already 6% have been exposed. So those are the people who already carry the antibodies. Many of them would have been asymptomatic, who then are sort of this bunch of people that you can think of it as, the virus is trying to make its way between people. It's jumping from one person to the other. But once it runs against a person who's already faced the virus before, very likely it won't be able to get through that person. So you can think of these people as roadblocks for the virus. Now, Kiran also made the point, which, the very good one, which is that one thing that protects India in general is our young population. 65% of our population is under the age of 35, and most of these folks are going to have asymptomatic infections. The only risk category, as far as I'm concerned, is the kids under the age of 6 months or a year, because they have special risk even in the Wuhan data. But above the age of 1, all the way through to probably the age of 40, we're probably fine. And only after that, the other hypertension, diabetes, all these kick in as risk factors. And we only have 6.5% above the age of 65. So theoretically, to get to this herd immunity, we need to have 65% of the population that has been exposed, whether asymptomatically, preferably, or symptomatically. Theoretically, it's possible to get to that 65% without touching a single elderly person in India. Right? Theoretically, it's possible. The challenge is how you actually do it when we have joint families and parents living with us and all of this stuff. And my instructions to my mother, who's 82, is you are actually homebound till December, not till May 3rd, but really till December, because that's the phase at which I think, okay, she's safe, because then there's enough herd immunity that's really built around. So the answer to that question is, don't worry about whether you're asymptomatic or not. I think at this stage, it's much more a question of the serological surveys, which will have to be conducted, and will have to be conducted periodically, like every month, to show where we are in the progression. Because for disease modeling, we can't model much of a disease just based on
numbers. Yeah.
No, just watching the tip. We need to have the full iceberg, and for that we need the serology.
Yeah. Okay. I just want to bring Lakshmi in as well before I go back to Kiran, because there's a few questions that have come in on the vaccine as well. But Lakshmi, for you, one of the questions that were asked was, what about people, because there are reports that come in, people who are turned away from the healthcare system, even if they're showing symptoms and they're going in. So what happens to them? And the second question that I have for you, really, it's a kind of a double whammy. One is, of course, on naming conventions of the virus. We're seeing a lot of people call it the Wuhan virus, just as Ebola has come from the river or Zika has come from, wherever. So we're seeing that naming convention sort of kick in. Of course, we see Trump calling it the Chinese virus as well. So, I mean, that's a whole different conversation. That's one. And the second, this idea of the quarantine, this, self-imposed quarantine, sure. But the notices that went up on homes and on front doors, there was almost a medieval element to that kind of notice. I mean, was it just me or did others feel it too?
Okay, well, very interesting questions. Let me start with the naming conventions. We didn't have naming conventions before WHO insisted that we should have conventions that are sensitive. So, for instance, you could not have had the Spanish flu because it didn't originate in Spain, but we all know it is a Spanish flu because Spain happened to be the place where you had uncensored reporting of the epidemic. So in a sense, epidemics do get certain names quite inadvertently. I think more than naming conventions, which prejudice doesn't come just because somebody from the top tells you whether it is a Chinese virus or Wuhan virus. I think we just have to dig deeper into our own selves and prejudices come tumbling down. Right. So I think, of course, we have to be sensitive to naming. Of course, we have to be sensitive to naming. But on the other hand, I think just a token and a cosmetic adherence to naming doesn't really solve the prejudice. Like Ramanan said, there is this iceberg of prejudice. And if we just remove something or add something, it's not really going to remove the kind of virus that infects our minds and our prejudices. So that's one. I do think the question that you asked about hospitals turning people away and this medieval sense of the quarantine. It's very interesting. It brings me back to there's a deja vu about whatever I read now. And when I read something like The Pale Rider of Laura Spinney, I think there is a real fear and there is a real taboo when we deal with contagion. And that contagion might be smallpox that produces a certain kind of response to divinity, or there is this kind of medieval fear of contagion. I don't think as modern subjects, we're all necessarily so modern that we've overcome that prejudice. So I find it absolutely anathema. I find it obnoxious that we should have these kinds of medieval notices. But I'm not at all surprised that these occurred. I think in India, we have this real problem of an epidemic arising with globalization, migrations, interconnectedness, and also with very basic fears that draw from extreme resource crunch. What are you going to go and tell somebody who's working on a livelihood? And you tell him, okay, come, we'll give you some money. And you have all these images that are circulating in all kinds of mobile channels. And he or she does not have the wherewithal, the emotional wherewithal to process this information. So what does he or she do? So, you have this strange balance between, I don't want to call it vestigial medieval, as though there is just one section of people who feel that way. I think we ourselves are so full of prejudice, so full of fear, and unable to grapple with rationality in any sense of the term, that I'm not surprised at all by both acts of omission and commission. So I'm not surprised. I just hope that when this pandemic goes away, whenever it is, December, January 2021, we've learned some social empathy on the way to this, on this way to this terrible disease, because I'm absolutely convinced at one level that the world will never be the same place again. But then the cynical me tells me it'll be business as usual when we actually get over the pandemic. So I hope I'm proved wrong.
Right. I think that's a very interesting question. And I think I was having a conversation about the way people are sort of spending their time, under lockdown. And one of the questions was whether we can find empathy or an empathetic bone in our body, because at the end of the day, the pandemic does not know geography, it does not know race, it does not know religion, it does not know any kind of divisive structure that we like to impose on society. And yet we're finding ways nonetheless to find those within the pandemic. So that's, I think it's a question for all of us to kind of introspect on. But I'll come back to you Kiran, before we end the discussion, because we've got a few questions coming in, and we go back to the issue of the vaccine. Lakshmi just made the point. Whenever we come out of this pandemic, maybe in December 2020 or in early 21, and Ramanan says he's told his mother she can't step out of the house till December this year. So people really, really want to know. And one question that is asked is whether existing treatment or vaccines can be repurposed for COVID. I know you made the point that you have to identify the COVID antibodies separately, but can existing medication be repurposed? And we also know that Siddhartha Mukherjee, for example, is trying to work on treatments and vaccinations, and he's been involved with Biocon as well on projects. Is there something you have that you're working on for people to kind of sort of say, all right, fine, we see some light at the end of this tunnel?
So let me first answer your question about vaccines. So I think in India itself, we are trying, I know that Serum Institute is trying to do a trial or is about to start a trial on BCG vaccines.
Right.
Because yesterday or day before yesterday, Robert Gallo, who's a very well-known HIV virologist, actually recommended we should try polio vaccine. The reason being that this is a live attenuated vaccine which should kind of boost your immune system, and he felt that if you actually boost your immune system, you may be in a better position to withstand the COVID-19 if it infects you. And the same logic holds good for a BCG vaccine, because there's been a lot of discussion and debate about whether BCG vaccination has immunized us against this virus, or there's a lot of ifs.
We'll talk about that, yeah.
But having said that, we know that the BCG vaccine does boost your immunity. And therefore, they're saying, let's do one trial with BCG vaccines to see if we keep on vaccinating people with BCG vaccines, can we hold out till the actual vaccine comes, okay? And I have actually been discussing about this antibody approach, which I told you, that if you can actually develop neutralizing antibodies against COVID-19 in a bioreactor, obviously that could also be a very good treatment. So treatment is definitely something that will remove a large part of that fear, because the moment you know that people can be treated very safely and they're really it's really curing people or it's really helping people, then Ramanan may not be so scared for his mother to step out of the house when it's in the market. But I would say that until the vaccine comes, I think the world will be treading very cautiously. They will be very nervous. So we are hoping that at least some vaccine will come out sooner than later. As far as India is concerned, there are 3 or 4 very interesting vaccine programs that are being developed, but they are not even in a preclinical state. So unless it gets into human clinical trials, which I don't think it will for the next 6 months, which would be the earliest, I don't think you can have a vaccine from India. There are several vaccines from the US and from Europe and UK, of course, which are being developed. And I hope that one of them actually works. And I hope it's I can see that the vaccines being developed in the US, which are mRNA vaccines, are going to be very expensive and very, very difficult to deliver, because these are going to be delivered in a hospital setting. Now, I don't think those are the kind of vaccines the world can afford. So you really need to get to a basic vaccine which you can give as a jab. So many of these other vaccines that are being developed as that. So I'm just hoping that one of these will work. And in the meantime, let's keep our fingers crossed that some of these therapies that are being looked at also are very effective. More than anything else, I'm still very optimistic that given our young demographics and our young workforce, they should be quite safe. And if we can really demonstrate huge herd immunity through serological testing, I think we'll be in a much safer place.
Right. Okay, well, that's certainly a positive note to end this discussion on. Thank you all so very much for being a part of this. I know that every conversation that everyone is having on whichever platform and whichever means of communication they have today is around how we get out of this. I, for one, I tend to agree with Lakshmi when she says the world will have changed and yet it will be the same, because I foresee a world where we'll have to carry immunization passports along with our actual passports when we get on a plane or book a ticket. Because who wants to spend 2 weeks in quarantine when they're trying to go on holiday somewhere, right? So, we will see the future of travel, the future of retail, the future of hospitality, the future of entertainment as we consume it, communities. There's a lot of changes, that people are concerned about and talking about, quite beyond just the impact on livelihoods. But none of that we can really begin to address until the work of the scientists is done for the moment. So thank you all very, very much for being a part of this conversation.
Thank you.
And also remember, for all the viewers of this, follow Roli Books on Instagram, on Facebook, on Twitter, and Roli Pulse's new digital initiative. I had to say that, I forgot, but I remembered just before we close. So thanks once again.
Thank you.
All right. Okay.
Pleasure.